Hey guys, today we're going to go over anemia. So this includes iron deficiency, B12 deficiency, folate, which is also B9 deficiency, chronic diseases, and thalassemia. So anemia is pretty easy in terms of treatment wise because you're just basically correcting the deficiency. But honestly, I think the hardest part about learning about anemia is you're just trying to figure out the diagnosis and the lab values. So for this lecture, I'm just going to try and simplify that to make it easier for you guys to understand it. So let's start off with anemia. Basically, anemia is a condition which the number of red blood cells and thus your oxygen carrying capacity is insufficient to meet your body's needs. So at a broad level, you're going to see basically a decrease in either your RBCs, red blood cells, sorry, hemoglobin, or hematocrit, or you might see a combination of pretty much all three. So how hemoglobin and hematocrit, sorry, hemoglobin and hematocrit can vary with different populations. So that's why I said that it can be either because a normal hemoglobin in just a regular population is usually 130 in males and 120 in females grams per liter. But these values can differ with different ethnicities. For example, African Americans, I think, were seen to have a lower hemoglobin values compared to the average population. Um, and same with like smokers or individuals living at high altitudes, which may have a higher hematocrit as well. So patient presentation, you're going to see, basically you're going to see these three symptoms. The one I highlighted in red is pretty much um, you'll see in the initial phases. So that's basically your fatigue, a little bit of hair loss, and dizziness. And then as it basically progresses, that's when you're going to see more of the prominent symptoms of like the shortness of breath, tachycardia, pallor skin. Basically, to simplify it, just try to associate what kind of body system would be likely be affected by low O2 delivery. So you're going to see a bigger impact with like basically um, your skin system. Okay, so anemia lab values. Actually, let me just get everything on here. So hemoglobin is the protein in which red blood cells carry oxygen and is formed from iron. So whenever we usually think of anemia, we usually associate it with iron deficiency, but that's not always going to be the case. Let me go over, I'll get more into that, but let's go over hematocrit. So hematocrit is the volume of red blood cells compared to the total blood volume. This will usually be influenced by fluids. So a high value would usually indicate something like dehydration. So the body is trying to hold on to that water, or something like heart failure, which is like that buildup of fluids, because your heart is not pumping properly, leading to high volumia. And then something like low value would indicate something like bleeding or leukemia, but most importantly, a low value would indicate something like anemia. So basically these two lab values, hemoglobin and hematocrit, will tell us if anemia is present. Then the next step is to determine what kind of anemia does this patient have. And then that's where mean corpuscle volume comes into play. And mean corpuscle volume is the measurement of the average size and volume of red blood cells. Now, I know this is kind of like a lot to remember, but all you kind of just need to know is basically a low MCV value, which is less than 80, you'll usually get the values, is going to be microcytic anemia. And then 80 to 100 will be normocytic anemia. And then a big one is going to be macrocytic anemia. And so you're going to have something, and in microcytic, you're going to have something called thalassemia, which is a blood disorder. Then you're going to have your classic iron deficiency anemia. And then if you notice here, you're going to have chronic as microcytic and normocytic, because chronic disease is just going to be like a broad term, and this can range from anything from like cancer to something like chronic kidney disease, for example. Then you got sickle cell, which is also another normocytic anemia, which is obviously going to be more genetic, so you don't have to worry about too much about diagnosing that because the patient will often be born with it. And then macrocytic, which is going to be your B12 deficiency and your B9 deficiency. So the most you're probably going to be working with is basically, folate, B12, and iron deficiency is probably the one you're most likely going to see, because these are the ones that actually have treatment. But the questions that they'll get you with for like most exams is they're going to tell you like, how do you differentiate which anemia is which? Now, in terms of treatment-wise, we evaluate whether a treatment is working because we look at reticulocyte count, which is basically indicates to us that if it increases, that means that the bone marrow is producing red blood cells, which is what we want to correct the anemia. Okay, so let's start off with microcytic anemia, and we'll start off with basically, the bread and butter, iron deficiency anemia. So this can be a result of blood loss or decreased dietary intake or absorption, so something like celiac disease or H. pylori. So let's look at the labs for this one. You're going to have a decrease in ferritin, which is your stored iron. Makes sense. There's no iron to really store, so you're going to have a decrease in your storage because your body's trying to use whatever it can to produce the red blood cells, so it's going to take it out of storage. You're going to have increased transferrin, which means this is proteins that bind and transport the iron. So the body is basically trying to get as many iron scraps as possible to help with the production of red blood cells. And then you're going to have a decrease in transferrin saturation. So I think these two people kind of get a little bit confused. But transferrin saturation is basically how much iron the transferrin is basically holding. And if you don't have a lot of iron, you're going to expect like your transferrin not really holding onto a lot of iron essentially. And then treatment, very simple. It's just basically increasing that iron intake. So in your diet, you want to aim for about 10 milligrams. If you're menstruating, about 15 milligrams. And then if you're pregnant, about 30 milligrams per day. And if you can obtain it from your diet, then you're going to do iron PO, or you're going to do, in severe cases, IV iron. So this is basically a breakdown. So you got your ferrous fumarate, which is probably going to be the most common one you'll see, to your sulfate, to your gluconate. And ferrous fumarate pretty much is like the highest one you'll see in terms of elemental iron, and but it can be a bit rough on the stomach. So this is why there's the other ones which can be a little bit more gentler on stomach, or you can use the iron complex, which is Ferromax, which is not seen to be as efficacious, but it has better GI tolerability. And then I guess I should include counseling points on there, but basically you're going to counsel your patient to take the iron on an empty stomach because it needs that acidity to be absorbed better. And some people will tell you to take it with vitamin C or like orange juice to help increase the acidity of the stomach acid so that it absorbs more. There's conflicting research whether that is true or not, but I would just, for exam's sake, just stick with assuming that orange juice helps increase the concentration of the fumarate as well into your body. Now, they can also get brachyury stools if they're using like the liquid oral iron solution. That can also cause discoloration of like your teeth and tongue as well. And as I think it doesn't have that good of a taste as well. And in real life, patients will often find that it's really upsetting to their stomach. In which case, you can take it with food. It's not like an absolute golden rule. It does absorb better without food, but you don't want your patient to suffer as well. Or you can get them to switch to a different iron and try to make up for the elemental iron that they require for their dose. Okay, thalassemia. Basically, you're probably not going to see this one, but it's a blood disorder resulting in ineffective erythropoiesis, so that's your production of red blood cells, and you want to treat this with blood transfusions. And basically, it's diagnosed by looking at red blood cell distribution width. And because it's microcytic anemia, pretty much this is the only value you need to differentiate this from your iron stores, iron deficiency anemia. So basically, what this means, if a value is close to 0, it means that all your red blood cells are similar in size. So thalassemia will have a low red blood cell distribution width, where iron deficiency anemia will have a more high number, and that's pretty much how you differentiate the two. And I wouldn't go more deep into that. That would just probably be the broad to stick to. Now, this is chronic disease anemia. So this can be either microcytic or normocytic, and it's a result of some sort of underlying disease. So that could be like cancer or rheumatoid arthritis, infection. I think chronic kidney disease will probably be like the biggest player, because this one you need to know that you need to use darbepoetin to treat, because the kidney is involved in making EPO, which is erythropoietin, which is used to make erythropoiesis, which is the production of red blood cells. and I think that would be your most biggest one. But the other ones are mainly due to inflammatory causes. So let's look at our labs. You're going to have increased iron, ferritin, so stored iron. It may be falsely elevated due to inflammation. And it's sort of thought that the body is essentially hiding the iron from bacteria because it can be used as a food source. Whether that's not really true or not, it's kind of a good way for you to kind of remember it. Like inflammation, you always associate with some kind of infection. And then C-reactive protein, that's usually used as a marker for inflammation. And then, as I said earlier, your EPO levels would likely be decreased. I don't think you'll often see this in an exam, but usually if you see chronic kidney disease, you should think, oh, they're probably going to need darbepoetin or erythropoietin shot, because that's going to stimulate the red blood cell production in the bone marrow. And another thing to note that this requires iron, so you can't just give EPO by itself. You're going to need iron when you give darbepoetin. So transferrin and transferrin saturation can either be low or normal, so I wouldn't worry too much about them. But the other three that I highlighted is probably the ones you're going to look out for. So treatment, you just treat like the underlying disease, and that's going to help correct some of the anemia. Now, there's going to be severe cases where you might need to do like some sort of red blood cell transfusion, or you can use darbepoetin alpha, which is the EPO agent I was talking about. Now, some things to know about darbepoetin alpha is you're going to need iron with it, some sort of iron supplement, because iron is the building block that's going to be used to make red blood cells, because iron is used to make the hemoglobin, and hemoglobin is the thing in the red blood cells that's going to help transfer your oxygen molecules. Now, the reason you have to be careful with this is you need to be careful of the thrombotic events. So it should only be used if your hemoglobin levels are less than 100, and you're going to basically titrate this to a target of 115. You doing 10 to 20 grams per liter per month. Because if you go higher than 130, there's a higher risk of stroke and hypertension as a result. Okay, now we're going to get into the easy ones. Macrocytic anemia. So basically that's your B12 or folate. So let's start off with B12, which is going to be your pernicious anemia. I think I said that right. And this is likely going to be due to some sort of like GI intake or absorption problem, such as lack of intrinsic factor. So usually what you want to look out on the vignette is something sort of like saying that the patient had some sort of gastric surgery or whatever, because those gastric surgeries, that affects the release of the intrinsic factor and thus relating to B12 deficiency. Another one is metformin, but it's going to be unlikely this cause because you need to be on metformin for a really long time, and you need something along with the metformin that would cause the deficiency of B12, if like an inadequate intake of B12 in your diet, for example. And just to note, B12 deficiency takes a long time to occur because B12, from what I remember, it stays in your body for I think about almost like 3 to 5 years in your body. Like it takes a long time for it to decrease in your body. And one thing to know about B12, it's sort of involved in the it is involved in the production of myelin sheaths. So deficiency would result in something like neurological symptoms. So that could be like dementia, which I don't think is common, but it's something like paresthesia, which is that abnormal sensation of the skin, or ataxia, which is loss of muscle control, are more common symptoms I would think you would see in B12 deficiency. So labs, you're going to see the mean corpuscle volume of greater than 100, obviously. And then on top of that, you're going to get the homocysteine values, which is elevated in both B12 and folate. So now we need to differentiate, well, is it B12 or is it folate? And next we look at basically something called methylmalonic acid, or MMMA. And this is going to be unique to your B12 and not folate. So which is going to be increased. Sometimes in a vignette, they'll just give it to you and they'll just say, you do lab tests and you see like his B12 is decreased, but his B9s are normal. They usually sometimes they'll give you that, but in case you don't, you just pretty much need to know those two, and that's pretty much it. MMA and homocysteine. So treatment will just be your B12
which is by PO or IM, and it's going to usually be lifelong therapy. And resolution of the symptoms will take at least 6 months, but just the neurological symptoms alone will take about 2 months. With B12 as well, the oral tablets, I just wanted to make a note that the oral tablets, they don't absorb as good, which is usually why you give the injection, or the next best thing is usually go with the sublingual tablets. So either go IM or sublingual or PO. In that order in terms of increased absorption. Next is megoblastic anemia, which is your folate deficiency anemia. So this can be due to something like chronic alcoholism or pregnancy. Another fun fact with chronic alcoholism, if you also have it, it also leads to something called thiamine deficiency as well. So you need to take thiamine as well if you have chronic alcoholism. Oh my god, it's so hard to type on this. That is really bad, but anyways. Okay, you won't have the neurological symptoms like B12, but you'll have like the regular anemia symptoms, so that's like the drowsiness, hair loss, dizziness. Labs, so you're gonna of course have that increased homocysteine, so that's gonna tell you that it's either B12 or folate. So the next thing is to look at the MMA, and you're gonna have normal MMA. And then that's pretty much how you diagnose folate deficiency anemia. And you're basically going to do folic acid for about 4 months, even if the patient is pregnant. And then resolution of symptoms will usually take at least 6 months. Oh, shoot, never mind. Ignore this. That's from the B12. Okay, so folic acid will usually about 4 months for even if pregnant. All right, and that's pretty much sums up anemia. So like I said, if you can understand the diagnosis of symptoms, it makes it much easier because treatment is literally just, you're just treating the deficiency. Iron deficiency, you give iron. B12 deficiency, you give B12. Folate deficiency, you give folate. Thalassemia, which is a blood disorder, you need to give RBCs. And then chronic diseases, well, you're just going to treat the underlying chronic condition. And that's pretty much it. If you can figure out how to do the diagnosis, then you're pretty much solid for anemia. Okay. I hope this helps, and good luck on your exams, guys.